Welcome. My name is Dr. Mary Claire Haver, and I am a board-certified obstetrician gynecologist. I am also the creator and founder of Mary Claire Wellness. I'm an author of The New Menopause, as well as The Galveston Diet, both national bestsellers. This was a #1 New York Times bestseller, and this is my first live on YouTube. I am coming here today kind of as an experiment just to see how this goes. And I would welcome your questions. I'm going to turn on the comment section. So if you feel like you have any questions while we discuss today, I'm going to talk about one of the most difficult things in perimenopause, and that is the plethora of misdiagnoses that we see in medicine. So multiple reasons for this. Remember, I am a board certified obstetrician gynecologist. I am well trained in OB. I have great surgical experience, but I think I got 1 hour of mention of menopause in my medical school, a 1 hour lecture. And I know in residency, I had 6 hours total in a 4-year curriculum. We had no menopause clinics. We had nothing special going on for menopause care treatment. It was just kind of briefly mentioned and off we went about our business. So part of the reason for this lack of education and training around women after the health of reproduction, after our reproductive lives end, is the problem with how we think about women, I think, as we age. Medically, in studies historically, we're just kind of treated as small men. There's a lot of exclusion of females from clinical trials for things like cardiovascular drugs, et cetera. And women's health really gets siloed. So a report came out this week that for NIH funding, only 9% went to women's specific health of their entire budget. And of that budget, 0.03% also went to menopause. So huge problem. Here's the other thing. Perimenopause was never mentioned in medical school. Perimenopause was kind of an afterthought in residency. I just taught it was the transition from normal menstrual cycles to the ending of the periods, and it was just slow decline of estradiol levels. Well, nothing could be further than the truth. It's only in the last 2 or 3 years that I've learned most of this information. And so here's the deal. Average age of menopause is 51. Normal, which means the 95th percentile, is 45 to 55. Okay. Menopause is defined as 1 day in your life. Your menopause is 1 year after the final menstrual period, if that menstrual period was related to ovarian failure. Basically, I hate to use words that might sound a little scary, but this is truth. Women go through ovarian failure about 2/3 of the way into their lives. And we are expected to live the rest of our lives without the benefit of our estrogen. So perimenopause is a transition period. So why do females have menopause? We are born with all of our egg supply, all of it. And we have 1 to 2 million eggs at birth. And then by the time we start ovulating, we're down to about 300,000 or 400,000 eggs. Then in the ovulatory process, we lose about 10,000 each month, but we're also going through this continuous process of atresia. The unhealthy eggs kind of die off before anything happens to them. So by the time we're 30, we are down to 10% of our egg supply. And by the time we are 40, we're down to 3% of our egg supply. So what is perimenopause? So what makes us ovulate? What is normal menstrual cycle? So for a healthy woman, those of us, and that's about 90% of us, who had regular, pretty clockwork menstrual cycles, it begins in the brain. So there's 2 glands in the brain I want you to remember. You're going to learn some biology here, the hypothalamus and the pituitary gland. So the hypothalamus begins by sensing the blood constantly for estrogen. When estrogen levels get low, it sends a signal to the pituitary saying, hey, make FSH. FSH and LH are stimulating hormones coming from the pituitary that bind to the follicular cells around each egg. That is those follicular cells around the egg is where the estrogen, the progesterone, and the testosterone is made each month. Now, we do have another source of testosterone, a major source from the adrenal pathway and peripheral conversion, but it's about 40%, 30 to 40% of our testosterone production. So when we reach a critical egg threshold level where those same signals coming from the brain, the ovary becomes resistant. It can no longer respond to the same signal. The brain freaks out, says, where's my estrogen? Okay, it's used to that normal ebb and flow, that EKG-like rise and fall of our estrogen, progesterone, and progesterone levels each month. Testosterone is fairly steady state. And then the ovaries resist it. It can't produce. The egg, the brain freaks out. It sends more folliculating FSH, higher and higher levels, to force that ovulation to come out. We eventually do ovulate in perimenopause, most of us. And then, but we get these much higher surges of estradiol, much lower lows of estradiol than we ever did. And progesterone never kind of gets to where it used to be. And so what used to look like a beautiful EKG curve each month now becomes a zone of complete chaos. And every organ system in our body is affected. We have estrogen and testosterone receptors and a lot of progesterone receptors, but estrogen is almost everywhere. It's in our brains, it's in our bones, it's in our muscles, it's in our gut health, our brain health, our mental health, our cognitive abilities, our, so here comes a patient who walks into her doctor's office and she has multiple vague complaints. She's in perimenopause. She's still having periods, okay, whether they be regular or not. But something has changed. Something's not right, okay? She could be diagnosed with ADHD. She could be diagnosed with leaky gut. She could be diagnosed with fibromyalgia. She could be diagnosed with long COVID, interstitial cystitis, adrenal insufficiency or fatigue. She could be diagnosed with anxiety and depression. She could be diagnosed with fatty liver disease. All of them. All of these are affected by the changing of sex hormones and the loss of sex hormones in perimenopause and menopause. This is absolutely the truth. And so we in the menopause, in our world, constantly talk about, and there's actually data to support it now, that a lot of these diagnoses, especially right now, some of the long COVID, definitely the interstitial cystitis, and for sure adrenal fatigue, and the fibromyalgia are actually perimenopause. It's actually perimenopause. And the doctors didn't know because they weren't taught. The clinicians didn't know because they weren't taught. The functional medicine doctors are not being taught about perimenopause and what this change of hormones is doing, okay? And what that patient probably deserved was a trial of hormones to see if she got better. And then we see where she's at. Because I can tell you, these patients are dramatically improving with hormone therapy for the most part. So so I'm looking at some questions. You can absolutely, Britt, be menstruating regularly in the zone of chaos. Remember, the ovaries can respond. It's just taking higher stimulating hormones and they're not having the same response. So perimenopause begins well before the period actually stops. Oh, praise Jesus, someone cares. 17 years in medicine and no one can tell me or help me with transitioning into perimenopause or being in it. Getting the book, The New Menopause soon, shameless plug, and an extra copy for her best friend. So how to stop the weight gain, and you work out 6 days a week and the weight's still piling on. This is such a common complaint. This is how I got into this space, was through the nutrition end of it. So everything changes, including our body composition in perimenopause and menopause. So a premenopausal patient can expect of her body fat for 8 to 10% of it to be in the viscera. So that's belly fat or intra-abdominal fat. Just by becoming menopausal, nothing changes in her diet and exercise. The amount of visceral fat deposition will usually double or triple, just from becoming menopausal. Estrogen is a powerful anti-inflammatory hormone. It is protective in multiple organ systems of our body. And women on HRT have less visceral fat accumulation and deposition. Now, I can't say enough about lifestyle. Forever I exercised to be thin. I ate to be thin. Those were my two goals. Work out to be thin, eat to be thin. I had no concept of muscle mass, no concept of protecting my bones against osteoporosis as I aged, no concept about, how to keep from being frail or how to prevent dementia. Nothing. Everything was be thin and you'll be fine. Well, that no longer is true. Muscle mass is determining our resilience against disease as we age. So I'm reading the questions. Hang on. So what do you do? Definitely focusing on getting enough protein in your diet. Continue with the workouts. That is so important. consider hormone therapy. Really look at your nutrition, not just outside of, look at your magnesium, look at your vitamin D, look at these big nutritional markers, look at your anti-inflammatory markers, which is going to take blood work. All of this kind of works together. Okay, I'm reading the questions, guys. This is so fun. So glad I found you. I'm finding an OB who does premenopausal care, hormone replacement now. So great. So how do you do that? So on our website at thepauselife.com, if you go into the search bar, you can look up, go into recommended clinicians, recommended physicians. We have a list of healthcare providers, clinicians, nurse practitioners who are doing great menopause care. These are testimonials that were written by you guys, by my followers who felt compelled to have a to share their wonderful provider because they're hard to find. Also, so we have about 1,000 clinicians on that list, and so they're divided by country, by state, and by city. So hopefully you can find someone near you. I would call ahead, ask questions, make sure they're taking patients. Not all of them take insurance. I know it's a little bit of a gamble. There's some wonderful telemedicine providers, and on if you go to Instagram or YouTube or a link in bio, we have a menopause empowerment guide that is absolutely fantastic, and it's free. It's 14 pages, and it lists the telemedicine companies, who takes insurance, who doesn't, how much they charge, what you get for the, and I've vetted the 3 of them that are on there. So you can go and check that out. That's totally free. That is the free menopause empowerment guide from the Pause Life, from us. Let's see. Is there a therapeutic dose of estradiol shown to be preventative for dementia and heart disease? We have no idea. That is a great question. I would love to see those studies. They were never done. The studies only said, is she on HRT or is she not? And what is her outcome? And so it depends on age and how close. It's really the time away from menopause. Like, estrogen is better at prevention than cure. So if you have developed those diseases, estrogen is not that helpful. It's better at preventing the diseases. So starting young, starting for heart disease, starting within 10 years of your menopause. But most of that data comes from oral Premarin, from oral estradiol. And so no one's looking at the data today to say, what about these women who are now on bioidentical estradiol? How are they doing with cardiovascular disease risk? And experts in this area, unless we demand it, unless we pass laws to make this happen, do not see under the current guidelines. Like, remember, only 9% of NIH funding goes to women's specific health. That's including having babies. So we as post-reproductive people, menopause got 15 million out of a $43 billion budget in 2023. This is a lot of work that needs to be done. So that data is not available. I can't tell you if your serum estradiol is between X and Y, you're going to have decreased risk of dementia or heart disease. That's not how the studies are done. There were simply, is she on it or is she not? I'm reading the questions. Okay. What's the best time to get your blood work done to know what you need for HRT? If you are a year past your last menstrual period, and you're over the age of 45, you are a candidate. You are fully menopausal, and you will be postmenopausal for the rest of your life. You don't need blood work to prove that, okay? Perimenopause, remember, as I talked about earlier in this discussion, is a zone of chaos. There is not a one-time blood, urine, saliva test that is going to be diagnostic. In our clinic, we're trying to do a day 3 FSH and estradiol to give us a clue how close they are to perimenopause. It's not a great test, but it is something that's available. But if she is symptomatic, we're doing a ton of blood work in clinic, and we are ruling out overlapping causes, hypothyroidism, dementia, hypothyroidism, autoimmune disease, nutrition deficiencies, etc. So to make sure we're not missing something, but then the diagnosis becomes perimenopause. You know why? Because 100% of you will become perimenopausal before you're menopausal. That's just the way it works. Let's see. I'm reading. What is the normal dose? That's great. My doctor has me at 0.75 for estradiol. I don't know how long it takes to feel better. No more hot flashes is where I am so far. I was hoping for more. How long does it take? So it depends. So for mental health, remember, you have to change neurotransmitters, and that could take months. And so hot flashes, I tell my patients, If your hot flashes are not completely gone or significantly better by week 3 to 4, we need to increase your dose. So, but the rest, musculoskeletal, I mean, it could take months. It's a long time to decrease the ravages of inflammation. So it's so exciting. We have 239 people. I don't know if you guys can share this, but go ahead and share and keep making comments. This is really, really fun. I've never done a live like this, and I love answering your questions. You just got blood work. Since hair thinned, all of a sudden you're postmenopausal, plus can't put on muscle mass. So that is hormonal hair loss is definitely a thing that we see in menopause. It happened to me. I am using minoxidil and I've totally changed my diet, and that seems to have helped. I mean, I am gray. You see some of the gray here, but my hair has really kind of come back. And so I use topical minoxidil for a long time. I also do a little red light therapy. There's PRP. There's lots and lots of options, but you probably need to see a dermatologist. But not being able to put on muscle mass, check your testosterone level and see where you're at. You may benefit from some supplementation. Okay, so hi, Heart. Hi, Jamie. She's menopausal for 8 years. Me too. Thanks to you and your posse, you started vaginal estrogen, amazing, and an estrogen patch and progesterone. In early 24, better sex still hurts. Tight burns despite lube not fully happening. Testosterone. Testosterone will help with drive, but not with pain, right? I mean, it could help a little bit in the vulva, so it's worth a trial, but I think you need to see a specialist, to see what's going on. There's things like vulvodynia. There's other problems outside of just atrophy related to menopause, and if vaginal estrogen is not doing the trick, then you should see a specialist. I recommend following Dr. Jill Kraft, Kraph. She is a specialist in the vagina, health of the vagina and vulva. She's a wonderful follow. She is in Florida, like Tallahassee or somewhere in Florida, but Jill Kraft, MD, she's all over social. She's got tons of great information. Give her a follow and see if she recommends someone in your area. Let's see, I'm reading questions. Testosterone does, Loretta, convert to DHT. That is peripheral conversion of testosterone to dihydrotestosterone. And then that is what binds to the hair follicles, on the skin, giving us acne and male pattern baldness, like the temporal balding. So if that is an issue, you want to consider decreasing your testosterone dose, or considering something like saw palmetto or one of the supplements that will kind of weakly block the DHT receptor in the skin. Works really, really well. Weighted vest. I actually have mine right here. You want to see it? So let's talk about the weighted vest and why I'm a big fan. This is it. So this one's 12 pounds. The benefits for osteoporosis prevention in the weighted vest start at 10% of your ideal body weight. Okay. So for me, that is 12 to 14 pounds. And this is a 12 pounder. I do a lot in it. I work out in it. I walk in it. I do housework. I just took it off because my shoulders, I had it on all morning. It was getting achy. If you go to my Amazon store, we have this guy linked here. This was from Progesterone. I think it's on sale right now. You should spend, this brand has multiple, so you can't put weights in it. They come in, if you're in decent shape, I would start with about 10% of your body weight. But if you're sedentary, start with 5%, invest in that, and then work your way up to 10% for the osteoporosis prevention. But there were studies that looked at balance, looked at bone density scores, looked at strength and muscle strength, and these were done in very postmenopausal frail women, and they saw improvement. So for me, if it works for them, it's going to be preventative for me, and that's why I wear it. Christy, that's how you find your gynecologist, using our recommended physician's guide. If you have our link in bio on Instagram or TikTok, it is in that link in bio, super easy to find. Let's see. When is your no flavor, fiber, and other supplements coming out? Soon. So my husband kind of runs the business back end of the supplement company. And so if you don't know, I have a nutrition supplement company I started when I was coaching on nutrition and menopause. And we have vitamin D, fiber, creatine, collagen, and turmeric. And so we are developing a protein powder that's going to have creatine in it. I'm so excited. And it's almost ready. We have an unflavored fiber coming out soon. Those of you who hate stevia, and I hear you, that will be coming out soon. You can put it in absolutely anything and it won't disrupt the flavor. But right now it has an orange flavor and it is sweetened with a little bit of monk fruit and stevia. And so we're trying to give more options. So that should be coming very soon in the new year. Your doctor said, stay on HRT only for 5 years. No longer a thing. The Menopause Society has said now, there is no arbitrary age or time at which you must stop your hormone replacement therapy. No age. Okay. And there is no increased risk of cancer if taken responsibly and correctly. So as long as for you, the benefits outweigh the risk, you are good to go. And so for some of you, it may be your whole life. You may choose to enjoy the benefits of estrogen plus or minus progesterone plus or minus testosterone therapy for as long as you can. And that's okay. That's okay. There's no age at which you must stop. So Sadie in Ireland, top of the morning. I can't do an Irish accent, Irish accent. Thank you so much for all you do for women. You are so very welcome. You guys are why I do it. After hysterectomy, is there any benefit to progesterone replacement in addition to estrogen? Much gratitude and best wishes. Possibly. So for my patients who don't require progesterone because they have an IUD in their uterus that has progesterone in it, or they have had a hysterectomy, or they were born without a uterus, that happens. It's rare, but it happens. Progesterone can be very helpful for sleep and like nighttime anxiety and restless legs. So I don't take it off the table completely. I would take it myself, even if I didn't have a uterus. I have mine still. I ran the gauntlet of my reproductive years with my uterus intact, despite having fibroids. So there you go. So yeah, for patients who are still struggling with sleep or waking up at 3 a.m, progesterone, chef's kiss. Okay, if you're 40 and you think you're in perimenopause, but you're not sure if it's safe to take HRT or low-dose birth control pill, this is such a good question and such a topic of debate. So so the biggest difference between menopause hormone therapy and birth control, can y'all tell me? Let me see in the comments. What do you think the two biggest differences between menopause hormone therapy and birth control are? What do you think it is? Let's see. I'm looking at the comments. So there's a couple of things. There's really two things. Okay. All right. Britt says birth control is artificial hormones. That's partly right. Hormone dose. Okay. Yeah. Those are the two big things. All right. So we have dose and we have formulation. Let's talk about why each were created. Okay. Each were created to make pharmaceutical companies money, by the way. But here we are. Welcome to capitalism. Birth control pills were developed first, and they were developed to stop ovulation. Okay. That's it. It was so long ago that they did not know how to make the bioidentical form. The easiest, cheapest way to do it was something called ethinyl estradiol. Now, there's some benefit to ethinyl estradiol which is synthetic. Okay. So most birth control pills, not all, but the vast, vast, vast majority have ethinyl estradiol as the estrogenic component, synthetic. Okay. You ingest it orally, you take it orally. It goes to the liver for quick processing where it does not it works a little bit differently. And most of that estradiol is broken into estrone through this conjugation process. Okay. So to a weaker estrogen, which is why the dose is like, if you look at ethinyl estradiol versus plain estradiol, 1 milligram, 1 microgram. So 1 microgram of ethinyl estradiol is equal to 100 to 150 micrograms of estradiol. So it's like 150 times potent. So when you're talking apples to apples, most menopause hormone therapy now has estradiol, straight up bioidentical. Okay. But most birth control pills are synthetic. So that's a big difference. So dose and formulation. So Birth control pills were developed to stop ovulation. You need a much higher dose to do that, okay? Whereas most menopause hormone therapy was developed to stop a hot flash, and you need about 10 times less of the dose to do that in general. So they do not make birth control pills currently that have non-synthetic options available. They're almost all ethinyl estradiol plus a synthetic progestin. And they're much higher dose than you would get in menopause hormone therapy because you need a much higher dose to suppress ovulation. So two big differences, formulation and dose. Do I wish there was a birth control pill option, or I could just have estradiol in multiple strengths? And I know not the vast majority of women, we will stop ovulation at this dose, but we don't. It's not there. We don't have it. So I would love that. I would be absolutely, I think they're working on one, but I would prescribe it left and right for my patients who needed ovulation. So you're in perimenopause. So we have, do we do a birth control pill, dose, pill, or do we do a menopause hormone therapy? Okay. Well, depends. Does she need contraception? We're going over here. We're going to go birth control pill dosing. Okay. Does she have irregular heavy periods that are driving her crazy and we need to control her periods? We're going to go over here. Are we having terrific cramps that are absolutely driving her crazy? We're going to go over here. Is she having horrible acne? And we, anytime we want to suppress ovulation and get the benefits from that, we're going to go over here. And some doctors, especially the older menopause practitioners, feel like that is the only option. The only thing to do is suppress and replace, suppress and replace. Now in this new world in menopause, people who actually, are treating perimenopausal patients on the daily, we can just support, and you can support with progesterone only for anybody. I don't do that a whole lot, but a lot of practitioners do. So early in perimenopause, especially if sleep disruption is her biggest thing, giving her progesterone only could be a viable option. Also, you could give her testosterone if libido is an issue, depending on her symptoms, right? Only. Estrogen is also an option at the lower dose. It's not enough to suppress ovulation. So she's still but it's enough to kind of calm the brain down. For mental health, some people may choose to add in a low dose estrogen just to get that FSH level down and to get the hypothalamus to calm down. You're getting just enough estrogen to kind of let the brain take a breath. Now, not a lot of studies on A versus B versus C. This is trial and error. This is really, really trial and error. So I hope that helps. But yeah, the biggest thing is formulation, synthetic versus bioidentical. The second biggest thing is dose. And we don't have, I would, I love having options. I sometimes give synthetic progestins to my patients, or SERMs, like a beta-doxyphene, depending if they're not tolerating progesterone, and some patients don't. I love having options because not everybody, it's not cookie cutter. But what I wish we had was a bomb-proof bioidentical option and the higher dosing to suppress ovulation. I think there is a huge financial opportunity for a pharmaceutical company to develop something like that. But that's just my 2 cents. Okay. I've had my tubes tied for 13 years, and my OB-GYN tried to put me on birth control for perimenopause symptoms. Not an unreasonable option, especially a lot of docs have no idea how to treat perimenopause and they are winging it. And we have patients I was on birth control pills in perimenopause because I needed contraception, and I had polycystic ovarian syndrome. So I wanted to suppress that, and it worked out great. Okay, so you asked for the bioidentical estradiol and patch and progesterone, which is option B, which is a completely reasonable option in both situations. Okay, thank you for coming to my experiment. I need to jump off. I have another call. I had so much fun doing this. I'm going to do it again. This was my first YouTube stream live. I had to download streaming software, get out my headphones and my fancy microphone. But I think it went well. Have a fabulous day, everyone. And please, please, please share this video, and we will chat again soon.